today is a very extended this session. Dr. Kim Kim Hong Anh, she will be talking about the next pre-decimal endothelial keratoplasty is a very the sound very good technique and also good result for the patient after the patient have a corneal damage after cataract surgery, and so please for your presentation today.
Dear Board of Directors of Vietnam National Eye Hospital, dear colleagues, thank you so much for the opportunity to speak at one of the finest eye hospitals in Vietnam and to present our work on new surgical approach to pre-decimal endothelial keratoplasty, PDEC. Corneal endothelial dysfunction is one of the main indications for keratoplasty. In 2021, according to the statistics of American Association of Eye Banks, the total number of corneal grafts harvested was 79,000. Out of them, 35,000 were allocated to treat endothelial pathology. So endothelial insufficiency can be both hereditary and acquired. The most common etiology would be Fuchs dystrophy and pseudophakic bullous keratopathy. The main mechanism here is irreversible death of endothelial cells, which leads to corneal edema, stromal opacity, and formation of epithelial bulla, and as a result, decreased visual acuity and chronic ocular pain. During the last 2 decades, posterior lamellar keratoplasty has been developing rapidly. The most common performed endothelial keratoplasty techniques nowadays are DMEK, decimal membrane endothelial keratoplasty. The average thickness of corneal graft here is 15 microns, and DECIDE, decimal stripping automated endothelial keratoplasty. The graft thickness here is 130 microns. So what is better, DMEK or DECIDE? According to a paper published by Guerra and his co-authors, DMEK is superior to DECIDE in terms of post-operative visual acuity and patient satisfaction. However, DMEK is technically much more difficult, and there is a higher percentage of graft dislocation than DECIDE. DECIDE, on the other hand, is a much more technically simple and established surgical procedure with low percentage of graft dislocation. However, best corrected visual acuity rarely goes higher than 0.8. In 2013, Professor Due and colleagues published a paper where they discovered a new 6th layer of the cornea, pre-decimal layer or Duas layer, which is situated between the stroma and decimal membrane. In 2014, Professor Agarwal and his co-authors published an article on new technology of endothelial keratoplasty called PDEC, where he transplanted Duas layer, decimal membrane, and endothelium by creating a type 1 big bubble. PDEC offers the best of both worlds, combining advantages of both DMEK and DCEP. So main advantages of PDEC are high post-op visual acuity, PDEC graft is easier to manipulate in the anterior chamber, better adhesion thanks to Duas layer, and no limitation in donor's age. The main disadvantages is that the graft size is not too big and the accuracy of needle step cannot be guaranteed. Therefore, there is a risk of bubble perforation with wastage of donor's material. Despite having many promising advantages, PDEC is rarely used, which is linked to difficulty in graft preparation. There are several complications related to formation of type 1 big bubble, such as risk of getting mixed type of big bubble, bubble rupture, stromal emphysema, and excessive trauma to endothelium. So the purpose of our study is to optimize the technique for obtaining and preserving PDEC grafts to reduce the loss of donor material and facilitate the transition of surgeons to perform PDEC. In order to do that, we use 30 scleral corneal discs and divide them equally into 2 groups. First group, classic PDEC, and second group, our optimized method. So for the classic PDEC, we can see here that the scleral corneal disc is put on a Teflon block or a flat surface. After that, we use a 30 gauge needle connected to 5 milliliter syringe, and we start to inject air into the middle layers of the cornea. We can see here that this method is extremely inconvenient because the cornea's position is unstable and the air tends to go out to the periphery and block our visualization. And therefore, there is always a high risk of endothelial perforation. in our optimized method, we use 4 devices. First is the ring fixator, special base for PTEC, syringe with spring-loaded plunger and storage media. So we put a sclerocorneal disc on a special base for PTEC. To secure the position, we put 4 30-gauge needles into 4 holes of our special base. Afterwards, we bend the needle, so the cornea now is stable. Then we put on some trypan glue for better visualization. Afterwards, we use 30-gauge needle connected to 5 ml syringe with spring-loaded plunger, apply ring fixator on top, push air until tap 1 big bubble is formed. We can see here that the size of the big bubble here is not too big, and we do it because we don't want it to be ruptured. And in order to smoothly enlarge it to necessary size, we use storage media. We can do it as many times as we want to. Here we received a bubble of 7 millimeters. Afterwards, in order to gain the size of 8 millimeters, we continue to inject the storage media. So here we received 8 millimeters. We puncture the bubble. And afterwards, we start to cut out the bubble circumferentially with Vanna scissors. We deflate the bubble. After when the graft is cut out fully, we remove the 4 needles. And here the graft is ready to be inserted in the anterior chamber. Here's a closer look of the devices that we have developed over the years. So here we have a ring fixator with a base. The ring fixator with the base helps us to prevent the formation of type 2 big bubbles because it shuts the fenestrations on the periphery of Duas layer. Also, the ring fixator with the base provides a stable position for the cornea, and therefore, you can see on the base there are 4 notches. One of the notch corresponds to the handle of the ring fixator, and the other notch corresponds to the place where the needle enters the cornea. Therefore, the needle step and the angle at which the needle comes in the cornea is regulated. And in the end, we use storage media in order to enlarge it to the necessary size. So here are the results of our study. In the first group, where the standard or classic method of PTEC was applied, only in 46% of the cases, big bubble type 1 happened. In 20 cases, big bubble type 2 or mixed type of big bubble, and bubbles rupture happens in 33% of the cases. In the second group of the optimized method, big bubble type 1 happens in 93% of the cases. In 6% of the cases, big bubble type 2 happens, which we converted later into DMAC. Bubbles rupture happened in none of the cases. Afterwards, when we have developed the technique for PTEC graft preparation, we have even thought of a way for PTEC graft preservation technique which can be used in eye bags. So, what are the main key points? We also pierce the bubble and we cut them out circumferentially. However, we leave 3 places attached to the sclerocorneal disc. We don't cut it completely. You can see here that the graft is attached to the sclerocorneal disc at 3 points. After that, the technician at iBank can just put it in storage media. And afterwards, when the surgeon wants to receive this donor cornea, he just has to cut these 3 pieces, and then he receives a full PTEC graft. This is a short video. So, sclerocorneal disc, ring fixator, 30-gauge needle connected with 5 ml syringe with spring-loaded plunger. We inject some air until type 1 big bubble happen. Put on some storage media to enlarge it to the necessary size. Afterwards, we use Vanna scissors to cut it. You can see here that it's very easy to use the Vanna scissors because the bubble holds the position of the graft on top of it. Here the graft is fully cut. Afterwards, we suck it into the Jaeger glass tube, mark the future descemetorrhexis area, perform the somatorexis with reverse Sinh and inject the graft into the anterior chamber using 2 spatulas to gently press on the corneal surface and open up the graft. And in the end, we fix it with gas-air mixture tamponade. On slit lamp examination, we can see here the results of a patient who had pseudophakic bullous keratopathy before and 3 weeks post-op. So in 3 weeks post-op, we can see that the corneal edema has significantly decreased. The visual acuity is high, but the most important is that the graft is very well attached to the posterior layer of the cornea, thanks to the dual layer. We have received 5 patents for our optimized technology. And in conclusion, I'd like to say that our technology for PTEC graft preparation allows to obtain big bubble type 1 in 93% of the cases with a diameter of 6.5 to 8.5 millimeters and significantly reduce the rate of all type of complications. A novel technology for PTEC graft preservation has been well proposed by, and can be used in eye banks, which prevents the risk of intraoperative donor material loss for eye surgeries. And in the end, I'd like to express my deep gratitude for my professor, Kalinikov, who believed in this idea and in me as his student and gave me a chance. Thank you for your wisdom, patience, and knowledge. Without him, of course, this work would be impossible. And I'm very happy to announce that our technology is now officially recognized and will be published soon in Indian Journal of Ophthalmology. And of course, it is also one of my biggest dreams to share this moment of happiness when we get not to only meet my hero, such as Professor Dua and Agarwal themselves, but also to receive an award for the work that was done. And on this note, I'd like to say that I'm very grateful to the board of directors, to the outpatient department, to my colleagues for the opportunity to present our work in this hospital, to listen to the advices and support of those who came here before me. Even though the time that I worked here was not very long, it was very meaningful. I learned a lot, made new friends, met top experts and teachers who generously shared their knowledge and set the standards high. I do hope to be able to continue present scientific works here and collaborate with doctors from our hospital. Because in this hospital, this is a place where great doctors work and a place with long time standing tradition of education, development, and growth.
Thank you very much, Dr. Mangai, for your presentation. It's very good and also very interesting for everyone here. So, any question or comment for Dr. Mangai? Professor Dong, would you like to ask something?
Thank you, Professor Sinh. Thank you so much for your presentations. And I wish you would speak Vietnamese so people understand more about the new techniques. But she said that it's more difficult for her to speak Vietnamese, so he feels more confident if she speaks English. But anyways, for the last sentences, I like to hear in Vietnamese because she used to be our member, our team, but she quit already. I very regret to say that. And because her personal issue, so she had to move. And our team, we lost one of the promising talent doctor. And from come back to our presentation, I highly appreciate your work. And I think that it's very difficult work. And you and your professor has invented a new way to do corneal transplantation. So we know we have a DSEC and DMAC, and PTEC, that's between DSEC and DMAC. It has an advantage of DMAC, but it has a lack disadvantage of DSEC, right? The advantage is we can use a younger donor, but for DMAC we cannot use younger donor. And of course, the more younger donor, the more endothelium cell we have. And for DMAC we cannot do that. But for PDEC, we can do that. That's one thing. And the second thing is that is graph manipulation inside the IC. So because it's thicker than DMAC, so we can easier to open it and put it in the receiver bag. And just I have a question to make more clear about the technique. First, what about the success rate? You said that the success rate is quite high, especially for the second method, the optimized one, the 93%. But for, I think that is one when you are very familiar with the technique. But when we are in learning curve, how success it is, and how long does it take to get 93% of the success likely or not? That's the one thing. And what about the outcome of the surgery? Here you just show the outcome of the graft reparation, but the outcome of the surgery, it means that after the surgery, after PDEC, how good the patient can see, and what about the complication rate? Thank you.
Dr. Long, thank you so much for your question and for your kind words. So regarding the first question, what is the success percentage rate for beginning PDEC surgeons? So this was the statistics that this was also our first cases. So the first time when we tried PDEC, we tried classical way. We tried classical way and we get all the complications that we saw. So 30% of bubble rupture, it was very scareful for us because the donor's material is not something that you can waste. You get type 2, which then you convert to DMAC, and then you get some sort of successful type 1. And we only after successful type 1, then you start to try. And afterwards, we tried and we didn't understand why we couldn't succeed. Afterwards, we bought, so Professor Dua, he has developed Dua's clamp that looks a bit like our ring fixator. But the clamp is like, it doesn't have a stable support, and therefore we still receive those kind of complications. And only after a while that we tried and developed this everything that we tried to maneuver, to think of a way to do it better, that were the results. So these were the results of our first PDEC cases. Yes. And we also cannot have more because the iBank doesn't give us more, so these were the first results. And as for the second question regarding the surgery, so PDEC IC has the same visual acuity as DMAC. But however, the graft dislocation rate is less because of the Dua's layer. So our first cases of PDEC we performed on a patient who had also glaucoma at the same time, and IOL dislocation, because many patients who with pseudophakic bullous keratopathy, after we perform PDEC or some sort of endothelial keratoplasty, they already have weakness in the zonules. So therefore it was even more difficult because air tries to escape through these weak zonules into the posterior chamber. But to our surprise, the graft didn't dislocate, and therefore we thought that this was a very promising new surgery to continue. And regarding to the third question, I forgot.
So if we have cornea,
Yes.
can you do the surgery here in our hospital?
If you have the cornea, I can prepare the graft because it was me who prepared the graft.
Okay.
Yeah,
But the second.
Yeah, we instrument for the preparing the cornea graft.
Yeah, so I have the first, the older version of the instrument.
Yeah.
But the newer version of the instrument is still in production in Russia. But the older is also okay. But because you can see there that the base for PDEC in the beginning, it was just a base that we use normally. And after that, in the operation room, we start to peel off the 4 notches. And then maybe we think how to center the cornea. So you have to have a central marker in the center so that you can see that it's in the center. So many new things added along the way. But if you have a patient like that, we will transfer the instruments fastly because it's not a problem for us and we can do it. But of course, for the second part of the surgery, when the surgery itself, it's my professor for me.
So normally do we need some extra cornea or not? I mean that we have two. If the first is not good, we can use the second one. Do we need I'm confident that we have only one is okay. I ask that because we can prepare for this cornea if you can do that.
Yes, so in the beginning when we first tried out our first cases, of course we had the second cornea because with the standard classic one there was bubble rupture, and then you started to wanted to do like a quarter of PDAC or a half of PDAC, like a quarter of DMAC, to try and put it in there to see what happens, but the bulla and the corneal edema stayed long. And of course in the beginning you need 2 corneas to secure. But after that, I think for now I'll say that 1 is enough.
Thank you.
Amen.
And congratulations.
Thank you so much.
Okay, thank you very much, Dr. Hoàng Anh. So you talking about Professor Duya. So before about 30 years ago, I already have a correspondence with Professor Duya. That time I was in Switzerland and in England, and at that time Professor Duya, he's chairman of Nottingham Eye and Ear Hospital. He gave me a chance to go to his department to study for 1 year. And after Bristol Eye Hospital, he gave me a chance, so I go to Bristol. But even though when I met his international English meeting, I already talking with him about 30 years ago. Just very long time, since 1993. And I also would like to ask you one question that you show us is manual preparation on the graph, but I know there's 3 techniques, and how about the Russia they apply? First, you can use the manual technique to take out the cochlea endothelial graft, and the second one we can use Moria keratoplasty to take out the cochlear graft is also very, very easy. And the third one we can use phantom laser. Like I told you that it is ZA by Switzerland. Also they prepare for cochlear graft is very good. And for the other question, I would like to talk with you by Russia. Когда вы изучите в России, вы читаете английская клиника или Россия клиника? Just for funny.
Thank you so much for your question. So regarding your question on femtolaser, we did develop the next femtosecond PDAC. So we applied the femtosecond inverted technique. So we applied the femtosecond on the scleral corneal disc endothelium upwards, and only afterwards we do hemodissection. And in that case, when the femtodissection already happened, it's even easier to expand the bubble because it destroys the adhesion between the dua and descendants membrane. So therefore, the bubble can even expand to 8-9 millimeters. But that's the topic for the next time. And second, your Russian is very good.
Я можно говорю много по-русски, сейчас я забыл. Я можно по-русски возить русский язык.
Спасибо вам за вопрос. Очень хороший у вас русский язык.
Tôi có hỏi câu là nếu mà bạn mà ở Nga ấy thì bạn đọc sách tiếng ngành y thì là bằng tiếng Nga hay là bằng tiếng Anh. Đấy, sau đấy thì trước đây thì nói thật là ngày xưa thì tôi cũng đã có thời gian đi phiên dịch của tiếng Nga được, nhưng bây giờ quên hết, quên nhiều rồi.
Và cuối cùng thì em cũng muốn cảm ơn anh chị thầy cô đã luôn giúp đỡ em trong thời gian qua. Vì ở Việt Nam thì thực ra là rất là nhiều mặt bệnh mà đến cả bên Nga cũng nhiều như thế. Và em cũng rất là buồn khi mà phải chia tay bệnh viện Mắt Trung ương, tại vì ở đây thì toàn là anh chị thầy cô rất là giỏi và đứng đầu ngành. Em cũng hy vọng là trong đây không phải là the end, trong tương lai em sẽ vẫn có nhiều cơ hội để gặp anh chị và học hỏi với anh chị. Cảm ơn chị.
Các bác sĩ có văn bản chắc còn hỏi nữa đúng không? Chị chưa kết thúc.
It's not the time to say goodbye now. I have some questions for you. Thank you very much for a very good presentation. As you know that for the endothelioplasty, the repairing the cornea is the most difficult. And for speedec, I think the most difficult during the techniques of the endothelioplasty. And so I'd like to ask you about the tip when you prepare the cornea for the PDEC. How to make sure that when you insert the needle in the graft, how you make sure that the needle reach to the beneath of the dural membranes and to inject the air of the solutions.
Thank you so much, Dr.
Because Dr. Thủy and I used to try to do it in the wet lab in our hospital.